Today we have a fantastic mix of questions that cover everything from hemolytic anemias and hemoglobinopathies to lab artifacts. Our first question asks to classify hemolytic anemias. This is a fundamental concept. Acquired hemolytic anemias are usually due to A. Extracorpuscular factors. Hemolytic anemia can be divided into two categories, inherited and acquired. Acquired is the red blood cell is born perfectly normal, but something in its environment attacks and destroys it. The problem is extracorpuscular factors. We are looking for external cause. Extracorpuscular factors are things like autoantibodies, as in autoimmune hemolytic anemia, toxin, infection like malaria or mechanical damage. B. Defects within the bone marrow. This is a typical cause of evaporation anemia like aplasia anemia, not hemolytic anemia. Intracellular factors and changes in hemoglobin stabilities. These describe inherited intrusive defects. They are the definition of an intracorpuscular problem. The antibody associated with paroxysmal cold hemoglobinuria shows specificity for CP antigens. Paroxysmal cold hemoglobinuria (PCH) is a rare autoimmune hemolytic anemia. It is caused by a specific type of antibodies called the donor-Lenstina antibody. This antibody has specificity for the P antigen on red blood cells. I antigen. It is autoantibodies with anti-I specificity are associated with cold agglutinin disease. A different condition often seen after mycoplasma pneumoniae infection. ABO and IgE antigens. Why antibody these systems are critically important in transfusion medicine and hemolytic disease or newborn. They are not associated with PCH. So think P for PCH. Here we have a classic case study. CBC, the patient has very severe anemia, hemoglobin 7.8 gram per deciliter, and MCV 118.5. It is macrocytis. The hints about the plasmia hypersegmented neutrophil. This was confined to megaloblastic anemia caused by either B12 or folate deficiency. The patient has pale, mild tachycardia and numbness in the extremities. This is a neurological symptom. Both B12 and folate deficiency cause identical megaloblastic anemia. However, only vitamin B12 deficiency causes neurological symptoms. So correct answer is B, vitamin B12. So a clinical laboratory scientist examined a right stain paraphrasmia and saw what appear to be small dark staining granules in mature erythrocytes. A second smear was stained with Prussian blue and positive results obtained. Based on this information, which of the following would you expect to be abnormal? So the key here is identifying inclusion. The description of Pappenheimer's bodies. Rotate granules are seen instead of ion overload. The body has so much ions that it begins to precipitate inside the red blood cells. Ferritin is the body primary ion storage protein in any condition of ion overload like hemochromatosis or cerebrosis anemia, the serum ferritin level will be high, reflecting the excess iron stores. So the answer is B, serum ferritin level. A bone marrow ME ratio of 4:1 would be an expected finding for B. Aplastic anemia. Aplastic anemia is a bone marrow failure characterized by hypocellularity and decreased production of all cell lines. The normal ME ratio 4:1 does not change in aplasia because the number of bone myeloid and erythroid precursor is decreased. In anemia such as sickle cell anemia, beta thalassemia major, or megaloblastic anemia, the marrow becomes hypercellular because of an increase in erythroid precursor, and the ME ratio falls. Accelerated electrophoresis reveals a large band of hemoglobin in the hemoglobin S position. This band quantified at 95%. The peripheral plasmia 70% targets the solubility test was negative. Based on this information, what is the hemoglobin? For this question, we need to know which hemoglobins migrate together on cellular acetate electrophoresis at alkaline pH. The major groups are E, normal hemoglobin, F, fetal hemoglobin, S, and C. Hemoglobin S, D, and G all migrate in the same S position. We have a large band in S position. This could be S, D, and hemoglobin G. But in here, solubility test was negative. So the solubility test is specific for hemoglobin S. If it is negative, we can definitely rule out hemoglobin S. This leaves us with hemoglobin D or G. Of these, hemoglobin D, specifically hemoglobin D Benjab, is the most common and clinically relevant. A previously healthy man experienced weakness and hemoglobinuria after taking the anti-malaria agent primaquine. This hemolytic attack more likely occur because of a deficiency of B. Glucose phosphate dehydrogenase. GCPD deficiency is X-linked inherited condition where red cells cannot produce enough NADPH to defend against oxidative damage. Primaquine is a classic example of drug that includes high oxidative stress. When GCPD deficient patient takes primaquine, their red cells are overwhelmed, leading to acute intravascular hemolysis, weakness, hemoglobinuria. This means hemoglobin in the urine. So the answer is glucose phosphate dehydrogenase. The hemolysis associated with infection by malaria organism is due to the A. Release of myrozoites from erythrocytes. The primary cause of hemolysis and the characteristic fevers in malaria is the lysis of infected red blood cells. This releases the new generation of myrozoites into the bloodstream to infect more cells. This massive simultaneous cell death is what cause of symptoms. Our last question is very practical. Problem about pre-analytical errors. We need to distinguish between true pathology and artifact. The description is majority of cells appear to have many evenly distributed blank spicules on their surface. So it is craniated cells, also known as echinocytes. While craniated cells can be pathological, examined in uremia, they are most often an artifact. The key is the Facender's 5 ml ETTA tube with only 0.5 ml anticoagulated blood. The tube is designed to have a specific ratio of anticoagulant to blood. When the tube is severely underfilled, there is a massive excess of ETTA. ETTA is a salt, and this excess makes the plasma hypertonic. Due to osmosis, water is pulled out of the red blood cells, causing them to shrink and form the classic crenated shape. This is very common artifact from the short draw. Thank you for starting with me. Keep up the amazing work, and I will see you in the next video.